We put this on the program really because we felt it was important for the very reason I mentioned early on, that we struggle as obstetricians, maternal-fetal medicine, sonographers, radiologists, and how to deal with irregular heart rates, fast, small, or intermittent ectopics. So, Fatima, do we have you? Can you hear us?
Hi, Simon.
Great, we can hear you.
Yes. Can you hear me well? Yes?
We can hear you clearly.
Perfect. So we are here with this baby that is 28 weeks, Nicolas. And, well, let's imagine that this baby has been referred because they suspect that maybe there is a rhythm anomaly, that maybe there is one of these arrhythmias that Julien very nicely has been showing it. So the first thing that I would do to check the rhythm is to start from the easy and then go to the difficult ones. So to start with, we can just go to the umbilical artery, as also Julien has explained. Well, this baby moves a lot, but let's hope that we will manage. So, well, okay, let's try to find another loop that doesn't move that much. So we are going to look at the umbilical artery because the umbilical artery will reflect for us the ventricular contraction, no? And then will tell us what is the ventricle doing. Yeah. So if it does not move, and then we can sweep the baseline, and then let's hope it will remain still for a while. And then we can see, well, it's because it's breathing, it's moving, it's very active baby, but we can see here the ventricular rhythm. So, for example, we can measure the heart rate and to measure heart rate.
Sorry?
To measure the heart rate, fetal heart rate. How many cycles? 2 cycles.
2 cycles.
Okay, so we can measure whatever, 2 cycles, and then we can see the heart rate. And yeah, this will be the ventricular heart rate. Yeah, and then if there is an irregularity, if there is a extrasystoles, we will be seeing, or if it's bradycardia, we will know. At least we will be able to see if it's bradycardia, tachycardia, or if there is an irregular rhythm. But this is just to start with. Then we will need to somehow look at the same time at the ventricular rhythm and the atrial rhythm. To do so, we have several ways to look at it. And then we will be able to do that with Doppler or with M-mode. Yeah? So let's now go to the heart. So we are going to move to the heart setting to do a little bit of zoom. And then let me close the angle a bit. Okay. And then one thing that we can do is to look at the same time at the mitral at the mitral and aortic blood flow. So if we look at the 4-chamber view, we see here at the same time the inflow in blue, in this case. Yeah. So here the inflow in blue. And then very, very close, the outflow of the aorta in red. That means that they are very close. So if we just go to this part and then go with the Doppler, open the size of the sample volume, we'll be able to get at the same time the aorta and the inflow. Yeah? So let's try to improve a little bit this. Okay. So here we have in negative, because it's in blue, the inflow, that it's biphasic. So we have the early filling and then the atrial contraction. That means that when the mitral valve opens here, there will be some passive flow going into the ventricle. That's the early diastole inflow. And then the atria will contract. So then here we will have the atrial contraction. Yeah? So that's the inflow because of the atrial contraction. And then if we go to the positive part, because we said that the aorta is going positive, that will be the aortic blood flow. Okay? So that means that at the same time, we are having the atrial, the mechanical reflection of the atrial contraction and the ventricular contraction. That means that here we can do several things. So let's try to close this. Okay. Okay. So we can first look if for each atrial contraction we have one ventricular contraction. You see that it's one atrial contraction, one ventricular. Atria, ventricle, atria, ventricle, atria, ventricle, atria, ventricle. It seems that it's 1 to 1, which is already very good, yeah? Because we can have that for each atrial contraction we have a ventricular contraction. And then we can measure the rate of the ventricle, the ventricular heart rate, yeah? We can also measure the atrial, well, the heart rate, measure it at the atrial contraction. That would be more or less like this. And then, very importantly also, we can also measure, let's see if I can close this and then increase the sweep again, not that much. And maybe come, for example, here. And then we can measure some time intervals. Some timing, just to measure timing, normal timing, fetal echo. No, timing, tiempo. Okay, well. So we can measure the time from the beginning of the atrial contraction to the beginning of the ventricular contraction, and then the time from, again here, the time from the beginning of the ventricular contraction to the atrial contraction, yeah? So that's measuring the AV and the VA time periods, yeah? So the normal thing is like this, yeah? So it takes more time from the ventricle to the atria, not the other way around. And then in some times of tachyarrhythmias, it will be very important to know these time periods in order to go to the differential diagnosis. So just having at the same time the atria and the ventricle will allow us to see so if for each atrial contraction there is 1, or if it's 2, 1, or if it's irregular or whatever, and then also to measure these time intervals. And we can do it here, that's perfect, and the mitral and the aorta, it's one of the easiest ways to look at that. But sometimes, for example, when there is very fast tachyarrhythmias, this is not that easy. So I think it's important to know other places to look at it, not just to know this atrial and mitral and aorta, but to have other places where you can go, you can see this, that you get at the same time the atria and the ventricle. And for example, another way of looking at it is going to the veins, no? To the pulmonary veins, yeah? We will go down a little bit there. Yeah, so we are like, imagine that you want to insonate the pulmonary veins. Do not breathe, no respires ahora, un momento. Okay. And then just, even if we don't want to, many times, we get at the same time the vein and the, no respires ahora? Okay. Because this is very close to the diaphragm. Okay, now. Better. It's moving a bit, but okay. So for example, here we are getting better, no? So in positive, we are getting the pulmonary artery, yes? So these peaks will reflect the ventricular contraction, and below we are getting the pulmonary vein, yes? So this notch here is the atrial, reflects the atrial contraction, like in the ductus venosus. No, here this in this way we also see very well. Yeah, so we have this pulmonary vein, and when we have the notch is the atrial. So we are having at the same time, this is reflecting the atrial contraction, and this is reflecting the ventricular contraction. So again, here we can see the correspondence between the atria and the ventricle, and we can measure the time periods of the AV-VA. Yeah. And then, as I'm saying, it's good to have like several places to do, because sometimes because of the position or whatever, it's good to know different places. Another place that we can look with Doppler at this correspondence is something that has been recently described, that you can go to the 3-vessel and trachea view. Let's see if the baby allows us to do that. So if we are going up and we have the 3-vessel and trachea view, and we go a little bit up, not just at the, well, now it has put some lip. Okay. Let's see if we manage that. Okay, we are here at the 4-chamber view, the aorta, and then we are trying to get to the 3-vessel and trachea view. And we go a little bit up. You see here? So, okay, let's go slowly. This is pulmonary artery, aorta, superior vena cava. And then, you see that here? So this is the innominate vein. So it's a vein that goes crossing before, no? So that would be the V, so before the V, and it's a vein that crosses and goes to the superior vena cava, yeah? So if we manage to get at the same time, you see that we can manage to get at the same time the aorta, that here it's in blue, and this innominate vein that here is in red. So if we put the Doppler here, we will manage to get again the atrial and the ventricular flow. I will open the gate sample a little bit, but this baby it's moving a lot. Okay, let's start again. Okay. If it keeps still a bit. So I need to go from the 3-vessel and trachea view a little bit up, but it's moving a lot. But here we are starting to get, yeah? So here in negative, we are having the aorta, and in positive, you see that I'm getting this innominate vein, that it again has this notch, yeah? So that's the innominate vein, and it has this notch, and this positive, this negative, so the innominate vein has a reverse flow, like when we have a reverse ductus ductus venosus, that it's reflecting the atrial contraction. So again, we have here the atrial contraction and the ventricular contraction. The atrial contraction, ventricular contraction, atrial contraction, ventricular contraction, yeah? So, well, the baby has moved. We don't know where we are. So it's moving super a lot. Yeah, but I have been trying to show like at least 3 places that with Doppler we are able to assess at the same time, yeah, the atria and the ventricle. And then another way to look at that, it's one that actually is the one that I love more because I find it very useful. It's with M mode. Yeah, so for M mode, we are going to first do the zoom. And then, yeah, I know that people does not like M mode very much or it's scary about M mode, but actually when you get used to work with it, it's very helpful and very nice. So for this, we need like an oblique view, like here. Not a transverse, not an apical, but an oblique view. Okay, that's not great, but let's start with, and then we can try to get it better. Yeah, so if we look up here, can we move the image up? No, no. Para mover la imagen de arriba. Okay. 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 So if we look up, we have more or less a 4-chamber view. The image has moved, but we have here, like would be that here in this top part are the atrias and the ventricles. So I put the heart like a little bit oblique. So because I want to cross at the same time the atria up here and at the same time the ventricle down here. Yeah. So, and then I'm crossing other things that I don't care. But the important thing is that I need to cross with the line of the M mode at the same time the atria and the ventricle. Because the M mode, what does is, I'm showing here a 2D image, and then I put a line. And then with the M mode, that it's one dimension, the ultrasound, what we'll do here, down, it's going to be reflecting what I slice or what I cut in this here. So first, there will be the lung. So here first, we will have some lung. Then we will be slicing the atria, and if we come to this part here, we see very nicely how the atria contracts here, yeah? So then it's another atrial contraction here, yeah? So we can be seeing the atrial contraction. Then it will like put some other things, the septum, whatever, but then at the end, we'll be slicing the ventricle. So if we go here, we see how the ventricle is contracting, yeah? So here, in a different way, we are showing at the same time how the atria, one atrial contraction, one ventricular contraction, the atria, the ventricle, the atria, the ventricle. So again, we are getting at the same time, in the same image, the atrial contraction and the ventricular contraction. So again, we can measure the ventricular heart rate, the atrial rate, and then also to measure the AB and BA relation. Yeah, I can try to get it again. So again, it's so not transverse, not perfect apical, but in an oblique position. Then we will need to zoom that. Maybe we can try to even zoom it more, so we will get a better resolution. And then, yeah, because we have this anatomical element. Let's see if the baby stays a bit quiet. No. Okay. No, it has. Where are you? No, it's very happy baby. Moving a lot, but not really. Okay, let's try again and see if it can keep still for a while. I don't know, Simon, if there is any question or comment in the meantime. I'm trying to do that.
Are there any questions at all from the floor, folks? Anybody like to ask any questions? Fatima, you started off very nicely and you showed the first thing that you do is you look for an arterial pulse. You then next move to the aorta mitral valve, then you next move to the brachiocephalic, left brachiocephalic vein. Do you have a preference? And then you follow by M mode. Very similar in a sense. You matched almost exactly with Juleni, who did the same thing, arterial M mode, and then looking at pulse Doppler across any particular artery and vein. Do you like you've shown the pulmonary circulation, you've shown the brachiocephalic vein and M mode. What's your preference out of all of these, Fatima? Or when you're faced with a rhythm disturbance, do you do all three? Do you?
No. Actually, you don't need to do the three. You just need to do one, well done, that you get really the relay. So because the information that you are getting, it's similar in all of them. So actually, what you need is to get one well done, so you can really see the atrial and ventricular contraction at the same time. You can see the relation and to measure. It's true that when there is bradycardia, and that the rhythm is slow, everything is easier because then everything goes slowly and then you can follow. And in these cases, usually I do the mitral and the aorta because to me it's very easy and fast to do. But it's true that when there is tachycardia, sometimes the inflow of the mitral gets fused, and instead of having the two waves, you have one, and everything goes very fast, and then you get lost. And then in these cases, I prefer to go to the M mode, because in the M mode, you get very nicely. And for example, when you have, for example, a flutter that goes super, super fast, with the M mode, you get these F waves that are very nicely seen in the M mode. So that's my preference. You don't need you need to do one, but it's true that if you are trained to do like several, better, because if of the position of the baby or because whatever, you don't manage to get the one that you prefer, at least you have another one. I would counsel to learn at least two of them. Yeah. And then also it's ideal to learn it in normal babies, not in a baby with an arrhythmia, because then things get complicated, and then if you never try to do that, then when you have an arrhythmia, then you are in a trouble. No?
Yeah. And Fatima, when you first showed the Doppler of the umbilical artery to get, as you say, as an expression of the ventricular rate, do you have a preference on sweep speed, or in fact for any of the Doppler indices, pulmonary veins, pulmonary artery, do you have a preference for the sweep speed in assessing rhythm disturbances? And if you do, could you show us maybe that?
So, okay, can you? I didn't regarding what just the ventricular rhythm, or you mean the Doppler?
So let's say choose the pulmonary artery, pulmonary vein. If we go to Dopplering in that region, and then just let's look at our sweep speed. It more struck me actually, Fatima, when you first showed the umbilical artery and you were measuring heart rate. the sweep speed seemed quite slow. You were seeing a lot of complexes, whereas you open it up, does it help you in seeing that discordance between the ventricular arterial and arterioventricular time intervals if your sweep speed is slower? Is that something that's helpful?
Yeah, so usually I just start with the sweep speed, the normal one. But then, for example, if I'm suspecting extrasystoles or irregular rhythm, I like to have in a sweep a lot of waves, so then I can have a better idea of that. Yeah.
Yeah.
But then if I need to measure AV intervals or I need to measure, of course, then I decrease the sweep speed because then I'm more accurate on doing that.
Yeah.
Yeah.
Super.
So usually, that depends on what you are looking at. Yeah. So if you want to go to see a lot of waves, then of course you try to do that.
And in terms of time intervals, when you show the different types of time intervals, do you refer to charts, or do you have on the ultrasound system the expected time in normal time intervals?
Well, there are normal values, but it's mainly to see if the AV and VA relation, if one it's longer than the other one.
Yeah.
Yeah. It's not that you measure the number, but to see the relation. And then it's true that if, for example, you are following a patient with anti-Rho, anti-La antibodies, and you suspect, you are trying to see if there is maybe a beginning of an AV block, then you can measure this AV relationship that reflects the PR interval. Let's see if I can get it here. And then in this case, the normal value it has to be below 15 seconds. Yeah? That's the normal value that more or less we check for that. So for example, here I will, let me close that and sweep speed. Okay. And then, for example, here if I want to measure this from the beginning of the A to the beginning of the aorta. So here it's 12, but it has to be below 15.
Yeah, very helpful. That's great, Fatima. Is there anything else you would like to show us? We've sort of coming to the end of scan time, but is there anything else you would like to show us, or are there any questions from the audience?
So the idea of this live scan was to show how we should proceed if we suspect an anomaly and how we look at this. So to me, I'm done, but if there is any question, we can...
I think we'll come back to the stage, if you could, Fatima, and then we'll open up for a Q&A for the whole session. Thanks very much. That was a beautiful demonstration, Fatima. Thank you.